The spinal cord runs through the spinal canal, which is surrounded by bones, the vertebra. And the vertebrae are connected to each other by paraspinous muscles, and then basically the entire body links together at the lower back. The thing is that you can have a problem with any one of those things and it might produce back pain. What I want you to realize in life, when you see real patients, most of the time, lower back pain is going to be non-specific, vague, musculoskeletal, needs nothing done. But on the test, because they can give you specific clues in the vignette, you have to be able to navigate your way through, is this musculoskeletal pain versus is this something else? So we're going to start off with first, how do you make that decision? Well, if someone comes in with the signs and symptoms of low back pain, you're going to ask them what their symptoms are, beyond just, do you have back pain? And if what you find is alarm symptoms, they now have cord compression. And cord compression is a surgical or medical emergency. If you diagnose cord compression, you give them steroids, dexamethasone, methylprednisolone, IV. The sooner you give someone with cord compression steroids, the more likely they are to have recovery. Now, it's not going to be as obvious as the football guy who loses his helmet and then has a head-to-head tackle. That person's obviously getting methylprednisolone. But you might have somebody who was going throughout their life having a cause of back pain that they didn't realize was significant, and all of a sudden develops alarm symptoms. That person gets steroids too. And once you get the steroids, then you have to do the diagnostic workup. Most of the time, it is going to begin with an X-ray. Although if you're giving steroids, you might just jump to the MRI. Because if it's that severe, it doesn't really matter what the X-ray shows, you're going to get the MRI anyway because you're preparing for surgery. You need to decompress the cord compression. And generally, that's going to be along the lines of draining hematomas, incision and drainage, antibiotics for an abscess, radiation for cancer, and surgery for a fracture. Depending what the underlying cause of the cord compression is, the management's going to change. What I want you to see is if you see cord compression, then you should give dexamethasone, then do the diagnostic step. Well, what are those alarm symptoms? How can you suspect this? Well, if someone's got bowel or bladder incontinence, saddle anesthesia, or really any focal neurologic deficit that's new or is rapidly progressing. You might use elements of the case to try to figure out what's causing the cord compression. Weight loss or a history of cancer for cancer. Fever and tenderness for an abscess. History of drug use. That's how you get those epidural abscesses. But it's going to be these things that are the alarm symptoms that push you toward cord compression. But most of the time in life, they're going to be non-specific, vague complaints that plant you in the bucket of musculoskeletal. With musculoskeletal, you don't have to do anything but NSAIDs and exercise. Now, this is important. Bed rest is always the wrong answer. You want them stretching, staying mobile, and treating their pain with over-the-counter acetaminophen or NSAIDs. And if you think it's just this non-specific musculoskeletal pain, you have them do this for 4 weeks. And you reassess. If what you find is that they have improved, you are right, it's musculoskeletal pain, and you're basically done. And now you encourage good lifestyle, continue stretching, staying mobile, exercising, using NSAIDs when it hurts, but workup's done, you're happy. But if it fails to improve, or in the history, you think you know what the answer is, that there are positive symptoms, and we're going to talk about what positive symptoms mean when we go through the individual diagnoses. If you think it's one of the more sinister diseases, you don't have to wait 4 to 6 weeks, because it's probably something else. And in the something else category, you're definitely going to get the X-ray first. Because if you have your answer on X-ray, you may not need more advanced imaging. But if you do need more advanced imaging because the X-ray is negative, MRI is the test of choice. And then you're going to get your answer, and we're going to talk about all these different diseases coming up, and generally involves some form of surgery. When you have cord compression symptoms, you give steroids and are going to go right to imaging. If you have musculoskeletal pain, you should get no imaging. But you do get imaging if you think you know what the answer is, and the answer is not musculoskeletal pain. Begins with an X-ray, then get an MRI. So let's talk about musculoskeletal pain first, because that's going to be the thing you're going to encounter the most. Musculoskeletal pain, the pathology, as the name implies, is going to be muscles. Generally muscle spasm. The patient is going to be young, so without risk factors for these other diseases, and is generally going to be male. There will be some heavy lifting, and their back hurts. But there won't be any of the symptoms that we're going to describe next. Musculoskeletal pain is not a diagnosis of exclusion. It's just that it won't have those things that are positive that push you towards imaging for more sinister diagnosis. And if you see the words belt-like, diagnosis is done. It is a clinical diagnosis, and the treatment is exercise and NSAIDs. Okay, so then when should you suspect something else? And that's going to be each of these diagnoses we'll go through one at a time. Disc herniation is going to sound a lot like that musculoskeletal thing I just described. And in disc herniation, you have the nucleus pulposus pinching the nerve. Now, that nucleus pulposus gets expelled from between the vertebra when a 30 to 50-year-old male does some heavy lifting. See, it compares to musculoskeletal pain. And they have lower back pain. But the person with a herniated disc is going to complain of sciatica. Lightning shock pain down their leg. And they're going to have a positive straight leg raise test. When you lay them on their back, keep their legs straight and lift towards 70 degrees, they're going to get that same sciatica pain. And that sciatica pain can also be accompanied by any of the neurologic complaints associated with a nerve impingement. The diagnosis is going to begin with an X-ray, which will probably be negative in a herniated disc. And the best test is an MRI. The treatment, though, is interesting. Neurosurgery is better than conservative management at 6 months. But neurosurgery is equal to conservative therapy at 1 year. So the decision to operate is going to be based on the severity of the neurologic impairment and what the patient is doing. The 30-year-old athlete who herniated his disc doing heavy weightlifts, who wants to compete again, will probably want neurosurgery. The older guy who doesn't have that bad dysfunction may just want to do conservative therapy. But it's going to be surgery or conservative therapy based on the severity and the lifestyle choices of the patient. But if you have the symptoms of sciatica, you may not have a herniation. It may be an osteophyte. The path here is a bony spur that grows into the canal where the nerve exits and pinches the nerve. Both of these are generally asymmetric or unilateral. In osteophyte, you're going to have an older person. It is most likely going to be a guy to confuse you with herniation, but there will be no heavy lifting. Older, no lifting, and sciatica with a positive straight leg raise, maybe some neurologic impairment, is probably going to be an osteophyte. The diagnosis is made first with an X-ray, which is generally going to be negative, and the best test is an MRI, which shows you the bone spur. Now, unlike herniation, this is not going to get better with conservative management, so if you're going to treat this, you're going to need to do surgery. But if you're old and you have back pain, it may not be an osteophyte. It may instead be a compression fracture. In this case, it's going to be osteoporosis. Now, I'm not talking about the person who gets into a car accident and gets ejected through the window, breaking their back. Right? It's going to be a comparison to osteophyte in the sense that this is going to be another old person, but it's going to be a woman, because women are at higher risk for osteoporosis, who falls on her butt. She, though, will not have sciatica and a positive straight leg raise. She's going to have the symptoms of a fracture. So you're going to see vertebral step-offs when you do your physical, and they'll have pinpoint tenderness. Now, pinpoint tenderness might be a fracture, but it might also be a metastatic cancer. It might also be a lytic lesion. It might also be an abscess. So these things aren't specific, but you take the old lady who falls and then has pinpoint tenderness where she didn't before, now you probably got a compression fracture. The diagnosis is made first with an X-ray, which is generally sufficient to diagnose an X-ray, but the best test is the MRI. Treatment here is going to be surgery. And then, oh, by the way, figure out what's going on with her osteoporosis. Either get a DEXA scan if she hasn't had one, or treat the osteoporosis. The X-rays generally give you a clue in the way of osteopenia. And lastly, if an old person has sciatica pain, but not necessarily lower back pain, they might have spinal stenosis. And this one is very specific, and you'll be able to spot it with ease. Once you know about it, you won't miss it. This is caused by a narrowing of the canal. And it causes pinching of the nerve. The patient's going to be old and present with pseudoclaudication. In this case, it might be a man or a woman. You're not going to really get confused with the other causes of back pain, but you might get it confused with peripheral vascular disease. They'll have claudication symptoms in their butt and in their thighs. And if you think about that, you must have blockages proximal to the area that's having the claudication symptoms, which means that they would have to have their femoral arteries be stenosed. And chances are, if their femoral arteries were stenosed, they wouldn't have claudication only in their butt and thigh, but also in the legs distally. And there's something about the claudication, more than just where it is on the body, it's also that it is positional. That is, if they're going upstairs, they don't have any problems. If they hunch over or get on an exercise bike, there's no claudication, but there is claudication when they're upright, walking around. That is spinal stenosis, not peripheral vascular disease. The diagnosis is going to start off with an X-ray, which is generally going to be negative. And the best test is an MRI. Treatment is going to be surgery with laminectomy. Okay, I'm not going to write these on the board because they're not really in the differential as we're considering it here. But other things I want you to be aware of in terms of back pain are going to be things like the visceral organs. So women during their menstrual cycle might have a little back pain, treated with NSAIDs. The old person who comes in from the nursing home might be constipated, and that's all there is, causing back pain. If you have back pain and a pulsatile mass in the abdomen, that's an aortic aneurysm that's about to rupture and needs to go to surgery. So there's lots of other things that go into the bucket of back pain. In this lecture, we talked about the low back pain, the lumbar region, trying to separate out what diseases sound like each other so that you can identify them on the test, recognizing that there's a lot of other stuff that causes back pain. So to review, the first thing you have to do is decide, are there cord compression symptoms? rapidly progressive or new neurologic symptoms, below the waist, cord compression, steroids. You can use the history to try to figure out which one of these it is, but there's no way you're not getting an MRI. On the opposite side of the spectrum, if they have non-specific symptoms, it's probably musculoskeletal just based on prevalence, exercise, and NSAIDs. If, however, you hit in the symptoms on anything that suggests one of these diseases, it is okay to forego the 4 to 6 weeks of conservative management and jump right to imaging, beginning with the X-ray, knowing the best test is the MRI, CT scan only if you're not able to get the MRI for, say, a pacemaker, and then treat according to the underlying diagnosis. Treatment is generally going to be surgery, and it is going to be based on the severity of their symptoms. That's back pain. Become a better doctor. Subscribe now to get access to our premium content.